All right, hypoxemia, again, we defined as a reduction in oxygen in the bloodstream determined by the arterial partial pressure, less than 80. Those values should not be anything out of the ordinary. By the way, Malley considers severe less than 35. I don't know why he did that, but so again, 60 is the point at which the oxyhemoglobin curve starts having that rapid deceleration, so you want to keep the PaO2 above 60 as much as possible. And male, we're going to ignore it. And I just told you why. So there. Hypoxia, again, is reduction at the tissue level. It can be local in the sense of, say, a cerebral vascular accident. You have a small part of the brain that's not being adequately perfused. That area of the brain now becomes hypoxic. Same is true with a myocardial infarction. Some portion of the cardiac muscle that is not adequately oxygenated, and you end up having ischemia developing, which, if not treated appropriately, will become injured and eventually will become infarcted. Or that hypoxia can be diffuse, as you might see in a patient who is hypotensive with a low cardiac output. There's poor oxygen delivery, and you can end up having it that way. O2 delivery, if you remember, is the oxygen content times the cardiac output, where you can subdivide those out to have your derivation of the oxygen content, looking at the attached to the hemoglobin plus whatever is dissolved, and then your heart rate versus in your stroke volume. And we know about all those wonderful things about stroke volume and the three determinants of stroke volume, right? You betcha. You betcha. Is it possible to have hypoxemia without hypoxia? Can I be hypoxemic and not be hypoxic? Yeah. A lot of patients end up in the ICU, end up with some hypoxemia. They become tachycardic, they become tachypnic, and they have compensatory mechanisms present, so they don't truly have hypoxia. Can I go the other way? Can I be hypoxic without being hypoxemic? Give me an example. Cyanide poisoning. It's one type of hypoxia. We can have a normal PaO2. Carbon monoxide poisoning. You get an anemic hypoxia present because you don't have functional hemoglobin, but the PaO2 is fine. In fact, the treatment for it is to give lots of oxygen. So what ends up happening is, for the most part, with pulmonary disease, the problem is that they don't have the ability to adequately oxygenate. PaO2 falls, and the body compensates through release of various hormones, for instance, erythropoietin, to increase the amount of hemoglobin that is produced by the, where else is it produced? In the bone marrow. But they also improve oxygen delivery through an increase in oxygen or increase in cardiac output. We know that there's a release of adrenergic sympathetic discharge, which as a beta-1 increases the heart rate as well as the force of contraction. Another fancy word for that, chronotopicity, chrono time, meaning I speed the rate up. Inotropicity, meaning that I increase the force of contraction. Problem is that that's going to put some more strain on the heart. In patients who already have a weak heart, it can be difficult when you're starting to, say, do a weaning trial on somebody who's got poor cardiac function. It's the ones you're going to see where their blood pressure spikes or falls, and they become very tachycardic and run into trouble. If the resulting, or if reduced cardiac output is resulting in hypoxia, say when you end up having an MI, that pulmonary compensation may not be able to be enough to improve oxygen delivery. So in other words, if I have a patient who has an acute myocardial infarction, reduced left ventricular function, reduced blood pressure, if they become if that fall in cardiac output reduces oxygen delivery, the ability of the lungs to compensate is not that great. They can only drive up the PaO2 so high and the saturation so high, can't do much else beyond that. Yeah, so that's basically what the last bullet point is saying. Oxygen deliveries decrease secondary stroke volume. The attempt is to try to increase ventilation, increase oxygenation, but it's not as effective. So really what he breaks down is looking at oxygenation from 3 different perspectives. One is external oxygenation, or external respiration, the transport of gas across the alveolar capillary membrane and loading onto the hemoglobin. Then the oxygen transport, taking that oxygen from the lungs down to the tissue, and then the internal respiration, which is what is done at a tissue level, where oxygen is unloaded and exchanged for CO2. And this is kind of the diagram that he has as far as external transport and then internal respiration at the cellular level, peripherally. So 3 things that we need to do to have external respiration present. I need to have some mechanism by which I bring gas into the alveolar capillary junction through the process of ventilation, the bulk movement of gas. I have to match that stuff that I'm ventilating in to the perfusion that is present. So there's got to be that perfect matching, ideally. And there's got to be the mechanism by which the oxygen diffuses across. So this is kind of the 3 that he lists as far as how that gas gets from the outside atmosphere proximal to the alveolar junction and then eventually diffusing across. PCO2, remember, is how we index how well we're ventilating. Some PCO2 less than 35 is indicative of hyperventilation, above 45, hypoventilation. And whenever we have hyperventilation present, one of the common causes of respiratory alkalosis is the patient's oxygenation level is low. 3 things are needed to have that bulk movement of gas in and out of the lung. Am I going too fast? I feel like this is a big review, but okay. 3 things you need to have a breath being delivered. First of all, you have to have some kind of neurological output. There needs to be a conducting mechanism between the brain and the diaphragm, in other words, the intact phrenic nerve. And then you have to have the diaphragm that's able to adequately contract and generate enough force so that you have a bulk movement of gas in and out. Here's an example of a patient who's, well, how would you classify that? With, is that, if this was on room air, is that a possible blood gas? Yeah, depending upon the barometric pressure, yeah. When you get above 140, you start to get suspect. When you get above 150, definitely becomes suspect. So here's another example of a patient, kind of similar blood gases, but now the PaO2 is low. Where the first one, they may be in a respiratory alkalosis simply because, Melanie's drawing the blood gas and she's digging around with her needle in her guy's arm and he's screaming. That's why he's in a respiratory alkalosis. The second one, what's the cause of the respiratory alkalosis? He's hypoxemic, yeah. First one, we just got to give him some sedatives, calm him down, right? Patient B, got to give oxygen to. So the management of the patient's got to be a little bit different depending. Are they both adequately ventilating? Are they both hyperventilating? Yeah. Okay. The way by which the body identifies hypoxemia and goes ahead and responds to it is through those peripheral chemoreceptors. Remember, there are central chemoreceptors in the medulla oblongata. There's peripheral chemoreceptors located in the aortic arch and in the carotid bodies. These are stimulated by a reduction in PaO2. So an alveolar PaO2 falls, leading to a drop in arterial PaO2. As blood passes by those 2 sites, there's impulses sent back to the respiratory centers, telling the respiratory centers fire more often and increase ventilation. It's also stimulated by an increase in hydrogen ions from an increase in PCO2. So as the CO2 levels rise, there's also a stimulus that's put back. Although the profound change is with oxygenation and suppression of those receptors. So they start kicking in at about 60, and they really become blunted and no longer function when the PaO2 gets below 30. Has anyone seen a PaO2 less than 30? I've seen it a couple of times. I had one guy, Gilbert. His PCO2 was probably normally about 90. His PaO2 was normally about 30, 29. He had no wiggle room. If he got a PaO2 a little bit higher than 32, 33, he would hypoventilate profoundly. If he got less than 26, he got goofy. So he was in this real narrow range of PaO2s. And this is where those two chemoreceptors are present, the peripheral chemoreceptors. As you can see, they're located in the aortic bodies and up in the carotid bodies and the carotid artery. There are also baroreceptors in these same areas. The baroreceptors respond to a drop in blood pressure. And in either way, they're transported back through either the glossopharyngeal in this case of the carotid bodies, or back to the vagus nerve from the aortic bodies, going back to the medulla oblongata to increase ventilation as a stimulus. Okay, that's kind of the mechanism by which the body tries to increase ventilation to compensate for hypoxemia. We know that as somebody with lung disease gets progressively worse, and as the disease is no longer functional, the ability to ventilate is impaired. PCO2 levels climb, bicarbonate levels climb to match it. And what you end up seeing is profound hypoxemia. The thought was always that you end up having them needing the hypoxia to be able to stimulate ventilation, something we would call the hypoxic drive theory. In reality, it probably doesn't exist, or if it does, it exists only to a very limited degree. They actually looked at patients with chronic obstructive pulmonary disease who had elevated CO2, so they were CO2 retainers, and they measured the diaphragmatic EMG, and when they administered oxygen, they hypoventilated. However, it had nothing to do with their diaphragmatic output. Their diaphragmatic output actually went up. So you would think it'd be the case of, gee, I'm knocking out their hypoxic drive by making them higher PaO2 than they normally live with. That must be the cause of it, and it truly was not. What it probably is that as you improve oxygenation, you alter the VQ relationship that is present, and you end up having an increase in the amount of perfusion to poorly ventilated areas, and that's what causes the CO2 to rise. Either way, I mean, to some extent, it's just an academic argument. But the bottom line is there are those patients, and it's not a great number, maybe 10-12% of patients who are CO2, who have COPD, that do respond poorly to oxygen therapy, and you have to be judicious in how you administer it. I'll tell you a little story. When I was at Providence, I got called over to do a blood gas on this lady because she didn't seem to be too arousable, and when I poked her, she didn't respond or move at all, and I'm good, but I'm not that good. Got the blood gas back, and her PCO2 was 140. Where normally it was running somewhere near high 60s, and her PaO2 was 120. Well, what had happened was she was on a couple-liter nasal cannula. They took her down for some sort of endoscopy of some kind, and they gave her some sedative to relax her, only what it did is it basically slowed her respiratory rate down. Now, if you remember back, high-flow or low-flow systems, if you reduce the minute ventilation, you actually increase the FiO2 in the process because you're taking in less room air to dilute it. And that's exactly what ended up happening. Had she been on a Venimask, a high-flow system, it wouldn't have made a difference. But it was just kind of an interesting clinical example of what ends up happening. You know that with unilateral lung disease, you end up having a problem. So if I have something where I have a huge right-sided pneumonia and no gas can get in there as far as ventilation, it's all going to go to the left lung. Oh, and by the way, at the same time, I have a massive PE on the left, which diverts all the blood flow to the right lung. You have a mess. You got a VQ relationship of 0 because I got ventilation going one place and perfusion going the opposite. We know that pulmonary perfusion is gravity dependent, so that in the upright lung, the primary area that is being perfused is in the bases, and there's less perfusion going to the apices. If I turn the patient so they're on their back, lying in the supine position, most of the perfusion then will go to the gravity-dependent regions. In other words, the posterior lobes. If I turn them on one side or the other, most of the perfusion will go to that dependent side. So perfusion is gravity-dependent. And this is where we get into West's lung zones. My old buddy John West. Actually, he doesn't know me, but I like him. The theory being is that you end up having perfusion exceeding ventilation in the bases. As you go up the lung, going from bases to apice, your perfusion pressure is reduced. And in theory, at least, in the upright lung, there is an area where you end up having no perfusion, but you have ventilation. What do we call a situation where you have no perfusion, but ventilation is present? That's called a dead space. Change a color other than white. White on white would not be good. So this is what we would consider to be physiological dead space. Right? Or more specific, I guess it should be alveolar dead space. What's the difference between alveolar and physiologic? That's right. So if I add my anatomic dead space to my alveolar dead space, I end up with my physiologic dead space. And this is kind of the graphic that West used to demonstrate that the reason why you have such reduced perfusion in the apices is because alveolar pressure exceeds arterial pressure. So you basically have the alveolus having such a high pressure that it compresses off the pulmonary capillary that's surrounding it. In zone 2, it's kind of variable, and in zone 3, you end up having no problem with perfusion. That's why the majority of the blood flow goes to that gravity-dependent region. When we ventilate, it's a little bit of a different story. So perfusion is gravity-dependent. Ventilation is gravity-dependent also, but also dependent upon the airway caliber and the stiffness of the lung. So the degree to which we can ventilate a specific area is dependent upon really the time constant of that alveolus. Now, remember the time constant? Okay, maybe you don't, so let me go back through that. Time constant basically says if I take my compliance, multiply it by my resistance, I'll get a number that will tell me how long it takes to fill or empty an alveoli. So somebody who has an increase in compliance and an increase in airway resistance, who would that be? Say what? A COPD patient, sure. They're going to have a very high time constant, which means it's going to take a long time for them to exhale. So we need to have a prolonged expiratory time, otherwise we risk air trapping. So just as the air will follow the path of least resistance, so whichever portion of the lung has the lowest airway resistance, that they will get the majority of the gas flow. Whoever has the highest compliance, they're going to get the highest amount of ventilation present. And again, we like to think that compliance is universal throughout the entire lung, but specifically in the case of patients with ARDS, it's a very non-homogeneous lung, and you end up having areas that are well ventilated, not ventilated, and over-ventilated all adjacent to each other. Oh, the lung box. Ah, soft feeling in my heart. All right. When I'm at a resting lung volume, let me rephrase that. When I breathe down to residual volume, okay, air goes into the apices first, and then it goes into the rest of the air, lung proportionally as you go along. At FRC, which is what we're focused with in most cases, the alveoli are already, the apical alveoli already have sufficient amount of gas in them. At FRC, there's actually a larger alveoli apically than there are in the base. If you don't believe me, tough, it's true. It has to do with the alterations in intrapleural pressure, the transpulmonary pressure that exists. So when you take a breath in, more gas goes to the bases in the upright lung than go to the apices because they're already full. Okay? So at FRC, notice that the apices have larger than the bases. So when I take a tidal breath in, there's a bigger distribution of gas to the bases than there are to the apices. Said another way, the distribution of gas is gravity dependent for both perfusion and ventilation. So as you go from the base to the apices, well, let me rephrase. As you go from the apices to the bases, think of it that way, going down, it's gravity dependent. And again, the reason being is that the difference between the pleural pressure and the alveolar pressure is definitely different between the apices and the bases. And I forget where this is out of. This is out of Beachy or somewhere else. Let me just kind of make quick mention of this. If you think about it, the lungs are just kind of suspended inside the thoracic cage, hanging there from the trachea in essence, like this bag that's there. So that means that the weight of the lung pulls down and actually causes a greater negativity, a more negative intrapleural pressure apically than they do in the base. Therefore, the transpulmonary pressure is greatest in the apices, which explains why that alveoli is bigger at FRC. This is all assuming that we're at functional residual capacity. Bigger alveoli there than there is here. So when I ventilate a breath in, proportionally, more is going to go here than here. Long-winded explanation as far as why ventilation is gravity dependent. Problem comes up is when we alter the airway resistance or alter the compliance. Now what we end up having is gas, instead of going to the bases preferentially, because the airway resistance is probably higher when you're looking at the airways in the bases, or the compliance in this case is higher, what we end up seeing is a shift of gas flow to the apices. So now, instead of it being primarily going to the bases, now some proportion of it is higher going to the apices. So let's say I had bronchospasm in the lower airway, more gas is going to go to the alveoli that are in the apices. If I have atelectasis in the bases, more is going to go to the apices. When I mechanically ventilate somebody, it's going to just be dispersed wherever it can. Well, it's easier to inflate those alveoli in the apices than in the bases. That's where most of it's going to go. The net effect of this is that you end up having a shift in perfusion. If you remember, what were the story with west zones? Most of the perfusion went here. Zone 2 was kind of a mix. In Zone 3, there was no perfusion, right? Or Zone 1, rather. This is Zone 1, this is Zone 2, this is Zone 3. What ends up happening when you start having some lung disease is you have an increase in the shift up here. You end up having more Zone 1. You and I sitting here have virtually no Zone 1. But when you start getting disease processes, this becomes more pronounced, which means that our VD-VT ratio goes up. And that's one of the reasons that we have ineffective ventilation going on, is because we're not putting the blood flow to the spot where the gas flow is going. Where you're starting to get that VQ imbalance. Yeah.
Why is there less perfusion in the bases?
There's not less perfusion. There's less perfusion in the apices.
You said when there's issues, then more perfusion goes to the apices?
More ventilation does. So you start having a disproportionate amount of ventilation going to the apices compared to the bases where the perfusion is. It's an imbalance. That's why one of the causes of hypoxemia was VQ imbalance. And this is the reason why it happens. Right? I have perfusion going where ventilation's not. In essence, you end up having a bigger increase in dead space. Normal distribution of perfusion. Increase the cardiac output. All I do is I make zone 3 bigger. No big harm. I still got ventilation going to the bases. Problem comes up when I start seeing a reduction in cardiac output or other alterations in compliance resistance or vascular resistance changing. And that's out of Malley. All right, what is this talking about? Yeah, so we ended up saying. The control of blood flow through the pulmonary vasculature is done on a regional basis, which is actually a very good thing. If I have a situation where I have let's say a right middle lobe pneumonia, I have a reduction in reduction in ventilation to my right middle lobe because it's collapsed and full of yucky stuff. That's a medical term, right? Okay. What would you want to happen to perfusion? Yeah, you don't want perfusion going to the right middle lobe. It's full of yucky stuff. It's not effective ventilation. So what the body does on a regional basis is it looks at what the alveolar PaO2 is, which is a pretty good index of how much gas I'm bringing in, right? If it sees something poor, it diverts blood flow away from there. Okay. So the body basically can control where it wants to put perfusion. You can kind of ignore that first bullet point because old generation isoprel was a perfect example. Isoprel would improve perfusion to areas that are poorly ventilated and cause hypoxemia to worsen. But since we don't use it anymore, you can kind of forget about it. Do you remember giving isoprel? Yeah. Well, talk about a bad effect of some people have with albuterol. Multiply it by 1,000. People were bouncing off the wall. And we'll talk about pulmonary embolism in a second. So this control of perfusion to various portions of the lung can be done under a very, very small region. If I recognize that I have poor ventilation there, I'm not going to send perfusion there. I'm going to redivert it someplace else. Oh no. This should be old hat, right? I have a reduction in alveolar PaO2. If you think about that formula, reduced FiO2, reduced barometric pressure, increased PaCO2, all of those things will make that alveolar PaO2 level lower. I can have a VQ mismatch. In other words, I end up having a shunt as the most common one, or just a VQ where I'm starting to see that perfusion being shifted to areas that are poorly ventilated. And you can have a diffusion defect. And let's stop there, because I think your brain hurts. Melanie?
So you said that, okay, so the body has the ability to send, if like, say you had right middle lobe pneumonia, and